Beta blockers are one of the most prescribed drugs in the world. They're lifesavers for millions with high blood pressure, heart failure, and even anxiety. But did you know the same drug used to treat heart failure itself can sometimes cause heart failure? If that sounds confusing, stick around as I break down the major cardiac side effects of beta blockers and explain the mechanism behind these side effects. Major cardiac side effects of beta blockers. This is the biggest confusion. While beta blockers are a cornerstone of chronic heart failure treatment and reduced left ventricular systolic function, the major cardiac side effects caused by beta blockers are the precipitation or worsening of heart failure. Before we dive into how beta blockers can precipitate or worsen heart failure, let's quickly review what beta blocker does in our body. The name itself represents that beta blockers block beta receptors in the body, so norepinephrine and epinephrine cannot bind to the beta receptors. There are different beta receptors located in various organs of our body. Each has a different location with a different pharmacological action. Let's explore the mechanism of beta blockers in the heart muscle, so we will focus on the beta receptors found in the heart. Remember this, the beta receptors located in the heart are mainly the beta-1 receptor. When norepinephrine and epinephrine bind to beta-1 receptor in the heart, leading to activation of the sympathetic nervous system, which further increases the force of contraction of heart muscle. This is called positive inotropic effect. This means the heart squeezes faster and harder, and ejects a large volume of blood out of the heart in each beat, which is called stroke volume. According to the formula, when stroke volume increases, cardiac output also increases. The total amount of blood pumped by the heart per minute is known as cardiac output. Beta blockers block beta-1 receptors of the heart and inhibit the binding of norepinephrine and epinephrine to these receptors. This decreases the force of heart contractility, which is called negative inotropic effect. When the force of heart contraction decreases, which means stroke volume decreases, consequently, cardiac output comes down. So, beta blockers reduce cardiac output, which is the heart muscle's ability to pump blood out of the heart throughout the body per minute. Based on the pharmacologic actions of beta blockers we have learned so far, I will demonstrate mechanisms of precipitation or worsening of heart failure in 3 distinct populations. Number 1. Healthy individuals. Number 2. Patients with pre-existing myocardial dysfunction. And number 3. Patients with acute decompensated heart failure. Mechanism of beta blockers precipitate heart failure. If healthy individuals take beta blockers, the reduction of cardiac output caused by these drugs is minimal, bearable, with no signs or symptoms. Beta blocker therapy in patients with pre-existing myocardial dysfunction and borderline compensation may cause cardiac side effects such as precipitation of heart failure. This is due to the negative inotropic effect of beta blockers, which is a reduction of cardiac output, and potentially push a compromised heart into failure. In this section, I explain the mechanism by which beta blockers exacerbate the signs and symptoms of heart failure in patients with acute, decompensated heart failure. In acute decompensated heart failure, a suddenly weakened heart muscle has a rapid decrease in its force of contraction and cardiac output. The body compensates for the resulting low cardiac output by activating of the sympathetic nervous system. This means more adrenaline and noradrenaline are released to stimulate beta-1 receptor in heart with the attempt to improve the diminished cardiac output. This is a last-ditch effort of exhausted heart to maintain cardiac output. Now, in this acute state, administration of a beta blocker and blocking beta-1 receptors in the heart can further decrease stroke volume and cardiac output, which exacerbates the signs and symptoms of heart failure. These drugs should not be started in patients with acute heart failure who are hospitalized in the intensive care unit or recently required intravenous inotropic support. For this reason, exacerbation or worsening of heart failure are listed as a cardiac side effects of beta blockers. In the bottom line, I will summarize what we learned so far. Number 1. Administration of beta blockers in healthy individuals may minimally reduce cardiac output, which is bearable with no signs or symptoms. 2. In patients with pre-existing myocardial dysfunction, the negative inotropic effect of beta blockers may reduce cardiac output up to the level that precipitates heart failure. Although this side effect is clinically significant, its prevalence is only 1%. For such patients, selecting an appropriate beta blocker and maintaining close monitoring is always beneficial. 3. In acute decompensated heart failure, our body activates the sympathetic nervous system to compensate for acutely diminished cardiac output, which is a beneficial compensatory mechanism, and the addition of a beta blocker to the treatment regimen worsens signs and symptoms of heart failure. While beta blockers are not recommended in patients with acute decompensated heart failure, 3 beta blockers, carvedilol, metoprolol succinate, and bisoprolol are a cornerstone for the treatment of chronic heart failure. These agents are recommended for all patients with chronic heart failure with reduced ejection fraction, unless contraindicated. In a future video, I will explain the pharmacological benefit of beta blockers in the management of chronic heart failure.
Thanks for watching. If you found this helpful, hit the like button and please subscribe to get future video lessons.